Hello, my name is Jay Kim. Looking into the camera. I'm a second-year clinical fellow graduating next week, and my scholarly project was on UW's longitudinal practice pattern for preeclampsia and a QI implementation. What's up?
The video one, just a second.
Oh, okay.
As you were.
Yes, yes. All right. Here's a table of contents. So I graduated from Brown University's community program at Kent Hospital for residency. And there we have a unique rotation at Women and Infants Hospital, where they have America's only IM-based 2-year fellowship in OB consultative medicine. And that's where I became interested in preeclampsia's pathophysiology. Preeclampsia is a life-threatening disease of pregnancy that is unique to humans. It causes sudden onset hypertension greater than 20 weeks into gestation, and it's caused by a dysfunctional placenta that releases all these factors like sFlt1 and Ing into the blood that causes widespread maternal endothelial dysfunction. And it causes multi-system end organ damage as a result that you can see listed on the right. And it is a leading cause of maternal morbidity and mortality worldwide. And in the kidneys, it causes this endotheliosis as our hallmark finding that we see. And the glomeruli show occlusion of the capillary lumen by swelling of the endothelium without increase in cellularity. And it resolves after the delivery of the placenta. A meta-analysis of 23 studies, including almost 6 million participants, found that patients who have had preeclampsia during their pregnancy are 4.9 times more likely to develop ESKD in their life compared to those who had normal blood pressure during their pregnancy. And causation correlation aside, it is a major health event that identifies these high risk group. And the conclusion of this study says that it may warrant closer monitoring and surveillance for long-term kidney disease. So what's in the literature? ACOG says that women and their PCP need ongoing care and vigilance, and there's recognition for more systemic postpartum follow-up. And there's even a call for standardization of coding practices to help address this. And there's no specific societal provider-oriented guidelines that are available at this time. The most comprehensive guideline I found is not from like a single journal, but rather a plain language position paper that's geared toward patients from the Preeclampsia Foundation in 2020. So I see that there is a problem. Going from OB-GYN to PCP care, there's no guidance on long-term follow-up. So the purpose of my project was to identify UW's current longitudinal practice patterns of post-preeclampsia population, develop a multidisciplinary peer-reviewed guidance for UW primary care to refer to, encourage a smooth transition from going from OB-GYN care to PCP care, and implement a dot phrase checklist that is simple for providers to use. For methods, it was a retrospective cohort chart review from July 2019 to July 2020. And I used ICD-10 codes looking through a slicer dicer to mine the MRNs. And that allowed me to review up to 5 years of total longitudinal data. It was UW births only, and I got the IRB approval in November of 2023, and I collected a bunch of data that I will share with you soon. For statistical analysis, there's no intervention or treatment group, so not much here, but chi-square was used comparing different practice patterns, and this is all descriptive data, so very little fancy stats were needed, but the data itself does tell a story, and I'd love to share that with you. The results, is really small. So approximately 2,000 live births at UW, and I got an N of 150. Uh, and our typical population, at the age at the time of the preeclampsia event, they were around 32 years old. Their baseline creatinine was about 0.6. ACE-ARB, 11 of them were on ACE-ARB prior to the preeclampsia event. The quantified proteinuria, 27 of them had UPCR or UACR. And our patients had a gestational age averaging 35 weeks plus or minus 4. We'll go into the race characteristics in the next slide. And 6 patients had CKD already, 36 had hypertension, 15 had diabetes or prediabetes, and 75% developed severe features during their pregnancy course. 24 patients had gestational hypertension, 19 had gestational diabetes, and the creatinine by the end of the study, so the latest creatinine we had by 2024 was around 0.68, only a little bit above the 0.61 at baseline, and the peak creatinine ever was 0.81. And you can see in the box and whiskers chart, I don't know if okay. You can see in the box and whiskers chart, the representation of this, and the peak proteinuria was around 0.43 grams per gram. And with the box and whiskers, we have the interquartile range in this box. So most were below 1 gram per gram, but we have a lot of these outliers going up to 18.5 grams per gram of proteinuria. And the creatinine, some AKIs are represented here in the outliers, but for a summary of table 1, this looks like it's a high risk group of people. Notice that they're only 32 years old, but a lot of them already have hypertension, diabetes, and this is the demographics breakdown by race. And notice how, and the right side is Seattle. Notice how the Black, Hispanic, and American Indian populations are represented larger in this preeclampsia population, visualizing what we already know about preeclampsia. I also looked into how many patients had underlying risk and got a preventative intervention. So ACOG recommends starting aspirin 81 milligrams to 150 milligrams for those at high risk. And high risk is defined as anyone with one of those in the top box. So if they've had preeclampsia in the past, if they had hypertension, diabetes, CKD, or autoimmune disease, or if they have 2 in the moderate portion, so the nulliparity, if they have obesity, family history of preeclampsia, Black race, low income status, age 35 or older, or personal history factors, like if they were low birth weight. And we found that 77 of our patients did not meet any of those criteria and did not get aspirin. 43 of the patients were considered high risk and received aspirin appropriately, and 30 of our patients did not get aspirin, even though they were considered to be high risk by ACOG. Though I likely undercounted patients who had indications due to this highlighted history. Because of the time frame, I was looking through LK archives, and it would have been very difficult to capture like low income, for example, or whether they had family history of preeclampsia. And some of the patients didn't get aspirin because the patient didn't want to take it, or some were late presentations, and polysubstance use had some part to do with some of them, or another person had recurrent nosebleed. So so it's not all provider practice. It's not a reflection of all provider practice. Table 3 is who followed them up and what did they do and how's the patient? Our provider data, 85 patients remained within the UW system. 15 patients were tracked through their Care Everywhere data, and 50 patients were either lost to follow-up or they were outside of our Care Everywhere system. Note that most of these women are young, healthy, women just raising their kids without a lot of symptoms and just living their lives. And even though a lot of them had no established PCPs on file, a lot of them did have laboratory follow-up with their subsequent pregnancies through OB-GYN. So shout out to OB-GYN for their role in primary care in medicine. For this follow-up, any plan for preeclampsia by PCP, out of the 100 patients who saw a PCP, I looked for preeclampsia in the plan section. So the auto-populated preeclampsia in like the medical history portion didn't count that. But if they had a concrete plan, that could have been anything, like aspirin in the next pregnancy, treat their hypertension, or even just a referral back to the OB-GYN note, that counted towards it. And only 15 of our 100 patients who had a PCP follow-up addressed preeclampsia as a hashtag problem. 50 of our patients got pregnant again, and 41 of them, 82%, got aspirin in their subsequent pregnancy. And for the denominator 114, recall that 36 patients already had hypertension. So from the 150, remove 36. 18 developed a new onset of chronic hypertension within the 5 years after they had that preeclampsia event. Proteinuria measurement. Top portion is a binary yes or no, did this patient get it? And the bottom portion is how many did this patient get? How many quantified portion, or how many did they get? On the top, notice that about a third of the patients got follow-up urine studies, and note that the N is pretty close to the number of pregnancy, the subsequent pregnancies. So about 50 subsequent pregnancies, and our ACR, UPCR tended to be from that pregnancy. And I think the bottom, the second portion, tells a more accurate story with the median being 0. We're just not really looking for subsequent proteinuria in these patients, some of whom have had like 18 grams per gram of proteinuria. Table 5 is a subgroup analysis looking at UW providers and comparing them to total and comparing them to outside hospital providers. And the only statistically positive or significant signal was proteinuria quantification, 67% versus 38%. And I wonder if this might be perhaps explained by their transfer to UW means that they are a sicker population. Some of them had eclampsia, and that was the reason for transfer, for example. And the small n, that may explain that difference as well. And figure 5 is just a visual representation of table 5. And this is honestly the data I had expected but feared. That having a UW PCP is not too different than the total sum of post-preeclamptic women, even when 50 of them didn't even have a PCP. For discussion, we went through the interpretation itself of the data during the results section, and we performed a retrospective cohort chart review of a vulnerable population aimed at capturing simple actionable items with the intention to proceed with QI implementation. Retrospectively, I wish I had collected some of the data listed here, including whether they were newly prescribed ASARB. I wish I looked at primary kidney outcomes rather than just looking at provider practice patterns. Lipid panel, tobacco use, counseling patterns, and changes in BMI and new incidence diabetes are things I wish I had looked at as well. For future direction, so while trying to apply what I had learned and distribute this, engage interest and implement a dot phrase, we found out that there was already a focus group between OB-GYN and UW's Women's Health Clinic that was working on transitions of care. And they actually I and they mutually converged on this idea, and they invited me to a Zoom meeting that involved OB-GYN, MFM, and the Women's Healthcare Clinic. And a survey was distributed to UW attendings and residents with an N of 6. There were 3 attendings, 1 fellow, and 2 residents that responded, and they were enticed with a $50 Amazon gift card. And these are some selected survey results. Left being strongly disagree, right being strongly agree. I feel there are clear societal guidelines on long-term follow-up of preeclampsia after delivery. So we have a left-shifted curve here. I regularly resume ACE-ARB in my albuminuria patients who have completed breastfeeding, and we have a kind of a bell curve there. A dot phrase of a list of best practices to consider in preeclampsia with references would be beneficial in my practice, and we have a right-shifted curve saying that most would be interested in such a dot phrase, and just a free response. And I just want to highlight the bottom portion. Just doing this survey feels educational. I definitely need clearer guidance on this topic. So here is what was implemented. So the right side is the latest version so far of a dot phrase, and the left side is a summary of all of that. Cardiovascular primary prevention, lifestyle risk factors, contraception, preconception counseling, blood pressure monitoring, more aggressive hypertension management targeting the AHAs 120, noting that these are higher risk individuals, regular UA with reflex proteinuria testing, regular lipid and BMP testing, and encourage ACE-ARB to be the initial antihypertensive of choice. And I'm proud to be a co-author with Dr. Maeda and Dr. Rieger for this. And while this may be simple general prevention guidelines that a lot of PCPs are already following, it does more than just act as a reminder. It adds ownership to the diagnosis of preeclampsia, because right now the way it is, they have preeclampsia, they deliver, OB-GYN's done, and PCPs, only 15 out of 100 patients had a plan for their preeclampsia. And even though I'm graduating, I'd love to be a part of any portion of this project going forward, which is really just starting. Perhaps if I work on this at my new hospital, if we do like a multi-institutional project, it might gain some national recognition to finally come up with the societal guidance that a lot of our PCPs are looking for. And preeclampsia itself is a topic I have a passion for, and I have more thoughts on the disease itself, but I'll conclude with these final points. Conclusions. UW's post-preeclampsia cohort was a higher risk population than the general population. Follow-up lab collection frequency was sparser than anticipated. UW's PCP practice pattern did not differ from the total follow-up pattern in the post-preeclamptic longitudinal care. Actionable plans for preeclampsia longitudinal follow-up was rare, despite being a known risk factor for future morbidity. A simple guideline may improve detection and primary prevention of cardiovascular and kidney risk factors and disease. And there is interest for this among UW providers. And we hope to implement a version of this dot phrase that was displayed in the future, starting with the Women's Health Clinic. For acknowledgements, I'd like to thank Dr. Maeda, who provided guidance as project mentor, as co-author of the dot phrase, and the leader of the hypertension clinic. And she has agreed to remain a point of contact if needed for the future in this project. Dr. Rieger, who is spearheading the implementation portion and also a co-author of this dot phrase. Bo, my clinical mentor, who's always a pillar in my education. Ashley connected me to OB-GYN. Megan connected me to a key player that connected me to Dr. Rieger. Ben helped me through the IRB approval process. Ian last week gave me some tips on statistics, and Carrie, Fanula, Maggie, and especially Danielle, where she, all of you for recognizing that this took a lot of time and gave me some dedicated time to work on this project. So thank you, everyone. This is a big teamwork. Questions? I think I saw Leah's hand go up first.
Jay, that was a great presentation. Apologies if I missed this. Did you look to see how many people have been referred to in the nephrologist?
Yes, 8. Or 6 of them had CKD at baseline, and 8 of them had nephrology follow-up. I actually had a graph comparing with nephrologists as well, and we had 100% UACR, UPCR checks for the patients. There are just following, you know, that UACR to EGFR, that table that NKF has. So it's basically that, but for CKD 2 and 1, I thought, 1 gram per gram might be a good threshold to actually see these people. If you think differently, please let me know. But most of these people who have the proteinuria during the preeclampsia, it resolves, but it's just not really checked. So I thought the UA, which is, I found $27 per UA, is a nice screening tool if it's persistent to reflex to the UPCR and to trigger that as a referral. Yeah, I like that.
I mean, these are bigger conversations and I think right now the doc phrase we left out with nephrology referral stuff, right? Or does it have?
It's
after, AS and ARB, blood pressure control, all the steps have been followed, and UPCR is still more than 0.5.
Yeah, and recall back to our table 1, most of them have normal creatinines too. So how many of them do we actually want to see in our clinic versus them just starting the ASARB? So the dot phrase, there will be multiple versions of this going forward, and I do hope to work on it with you. Yeah, I think I saw Sarah's hand the fastest.
I was gonna say, did you identify those folks who had much higher levels of proteinuria? Were those the ones with pre-existing CKD, or what was it about those folks?
The patients who had, so most of them didn't have, I mean, they're 30-year-olds. Most of them didn't have UPCR prior to getting pregnant unless they were pregnant before. So if they've had any sort of, so all the CKD patients, of course, had the proteinuria, but I think it was only 27, if I remember correctly, that had proteinuria.
But there were some folks who had like up to 8 grams with that.
Yes.
Who were they?
One of them had, I think there was a PKD patient, there was a morbidly obese patient, and there was one with cancer. A lot of the charts were actually kind of sad to look through, but those were the outliers. And the ones who had CKD at baseline, they did have nephrologists following as well, who some of them did have the plan for preeclampsia. I think the proteinuria, yes, 27 patients had proteinuria, but most of them were pregnant before.
Not really a question. It's kind of a question. But I'm just very impressed with the amount of stuff you did. It's a lot. There's like 3 projects in there. And then the fact that you did it with Laura, who's like very early career. It's just, anyway, very impressive. Are you going to present this somewhere?
I hadn't planned for it. Actually, I I need to work on it. Yes. I need to work on writing up an abstract. I don't know if I can meet that deadline, but maybe next year.
Get that.
Yep, yep.
That's similar.
I don't know. But that was, yeah, I was shocked within the 5-year time period. A lot of them were on or remained on those antihypertensives or just were on new ones like enalapril, which is the preferred one if they're breastfeeding. Yeah.
So I think presentation can be a great topic and a great presentation. So I think this thing is not only important for the women's health plan, I feel like without them also needed because we got those patients referred from outside hospital, that's preeclampsia, or when they came to us for something else, and sometimes like I personally sometimes forgot to ask those like history during the pregnancy, and I didn't realize that preeclampsia actually is related to the long-term kidney ability. So I feel like we need that part of education as well.
Yeah, yeah. Hopefully this will be a public dot phrase that'll be available for anyone to be able to use.
How long do you take for you to get a
Actually, once it was done, they approved it within a week. So it was the actual writing out portion that took time. The right, it's like a 7-page thing that I had to fill out. Yeah, a lot.
Amazing work, Jay. Very an unmet need that you have fulfilled. So I've been here long enough to say, okay, can we pull out Jimmy's Regal syndrome protocol? Can we pull out Barbara's hyperkalemia protocol? So I guess it's gonna go down as Jay's. Very well done.
Oh, thank you.
Just a quick question, not on this, just aside, just I'm interested. So you've done a sort of reading and search here. So Anil Thermanchi has been trying to come up with an SFLIX, test or now assay. Do you know if it's went anywhere? Is it available anywhere?
I don't know. From my understanding, it's only in the research setting or in Canada that they actually use it for clinical setting, but that's the latest I've read.
I was gonna ask, sorry, one last question. It's kind of related to Sarah's, so you can do with it what you like, but yeah, this strikes me, you kind of ranged the gamut of, research components. You came up with an idea and designed a project, you went through the IRB, you worked, did the chart review and analysis, worked with a team, then are doing it, intervention. Like, what do you think as a clinical fellow? How is this? What's your reflection on doing a scholarly project as a clinical fellow? It's a lot.
It took a lot of work.
Skill sets.
Danielle allowed me a lot of e-week time to allow for this to happen. And I do hope that this can become national because it's not like we're presenting new ideas. We're just following general prevention guidelines. But I think the ownership, it's like a nudge that we're saying like this belongs to primary care because OB-GYN, when they're done with delivery, they're done. So just having that on their plate, it's a simple thing that the PCP can do that would identify these patients as these high-risk patients. I maybe need to spend more time with them. And that's my hope going forward.
Yeah, you took ownership of a system level, issue as opposed to, building on like clinical work. It's a very different kind of experience. Anyway, thank you.
Thank you.